So, a problem posed in many epidemiologic studies is that we observe an association between an exposure and a given outcome, and then we're tempted to derive a causal inference when in fact the relationship may not be causal. This brings us to the subject of confounding and bias, one of the most important topics in epidemiologic research. So, if we observe an association between an exposure and an outcome, the first question we always ask ourselves is this a real association? Before we can talk about causality or generalizability, we need to make sure that the findings are valid. So, if an association is not valid, it could be biased or it could be the result of chance. And so a chance finding may arise simply because we didn't include an adequate sample size. It's possible that our sample was just too small, and so we just simply couldn't see an association. It doesn't mean that a real association doesn't exist between the exposure and the outcome. It just means that the sample that we selected wasn't large enough to see that difference if it truly exists. And that's something called the power of a study. It's why we always do a power calculation before we begin to figure out how big our study needs to be in order to see the findings that we want to see. So if we've ruled out chance, then the second thing we need to ask ourselves is, could the finding that we're seeing be due to bias? And bias, the definition of bias is that it is a systematic error in the design, the conduct, or the analysis of a study which results in a mistaken estimate of an exposure's effect on the risk of disease. So this is really important because if we observe an association and that association isn't real, and we conclude, we write a paper and we say that vitamin D deficiency is associated with cancer, that's problematic for a number of reasons, right? There are ethical concerns, there are financial concerns if people go out and try to buy supplements to reduce their risk of disease. There are potential policy concerns if we change policies to try to increase levels of vitamin D in the population. So we want the associations that we find in our studies to be valid. So there are a couple different kinds of bias. The two most common types of bias are selection bias and information bias. So a selection bias is a systematic error that comes about in the process of selecting our study population. So we may make an error in the way we select patients for our study in a way that biases our outcome. We're going to talk about that in a minute. The second type of bias is information bias, and this is a systematic error that occurs when we're measuring information in our study. So we could either misclassify exposure status or outcome status. Okay, so let's talk about the first kind of bias for a few minutes. Selection bias, I mentioned, was a type of bias that comes about in the way that we select patients for our study. And this bias selection process distorts the exposure-outcome relationship. So an example of this is that we may select volunteers as an exposed group and non-volunteers as a non-exposed group in a study if we're trying to measure the effectiveness of a screening program. And so if we're using volunteers as our exposed group, the problem with volunteers is that they tend to be a bit more health conscious than non-volunteers, and so they probably have less disease. We could also think about it the opposite way, that volunteers could be at high risk, such as having a family history of illness, and that's why they're agreeing to be a volunteer. And so it could be that you're selecting a group of individuals that either have more risk or less risk than the general population, and so you're biasing your exposure-disease relationship. We can also look at this bias sampling strategy in a figure. So let's assume our exposure was smoking. And let's say that we know that the true rate of smoking in our case group is about 50% and the rate of smoking in the control group is 25%. And so if we wanted to draw a sample to represent that population, if we drew a good sample, our sample smoking prevalence would represent the true prevalence in the general population. So our cases would have about 50%. and our controls would have about 25%. So a bias sample might mean that in this case, let's say we took our controls from the hospital, and so the sample that we ended up with in our study had a prevalence of 50% in our control group and 50% in our case group. And so you can see that we're selecting a control group with a smoking prevalence that's much, much higher than the general population, because we're selecting a control group that is unhealthier than the general population because they're in the hospital, right? So they probably have a higher smoking prevalence than you and I walking around in the general population. That's why they're in the hospital. And so the problem with this sampling strategy is that if we're selecting an unhealthy control group that doesn't represent the true population, we're not going to see a relationship between exposure and outcome, because you can see the smoking prevalence is about the same in the cases and the controls. And so in this case, in the correct sample, we would make a valid conclusion between the relationship of smoking and disease, where in this case, if we used an improper sampling strategy, we would have a biased outcome and we would fail to detect an association between an exposure and an outcome. So we might end up with an odds ratio of 1, suggesting there's no relationship. The problem, again, is that there really is truly a relationship, but we used a poor sampling strategy and failed to detect that. So we made a bad conclusion in our paper. So how do we design a study to minimize the selection bias? We have to think carefully about the study population that we're using. We need to define our selection criteria for the exposed and the non-exposed participants independent of disease outcomes in a cohort study. In a case control study, we want to take our cases and controls from the same population, or we could conduct a clinical trial, because clinical trials have the least amount of bias. So as we increase along the hierarchy of study designs that we've talked about, ecologic and case control studies being at the bottom, and then cohort and clinical trials being at the top, as we go up the hierarchy, those study designs have the selection bias, or the potential for selection bias, is reduced. Okay, so I mentioned there were 2 main types of bias. We've talked about selection, and the second one is information bias. So information bias occurs when information is collected differently between 2 groups, leading to an error in the conclusion of the association between exposure and outcome. So when the information is incorrect, there's a misclassification. Differential misclassification occurs when the level of misclassification is different between the 2 groups. Another way of saying this would be sometimes some of our controls are classified as cases and some of our cases are classified as controls. On the other hand, non-differential misclassification occurs when the level of misclassification does not differ between the 2 groups. A good example of this is weight. So most people systematically underreport their weight by 5 or 10 pounds. And so there's really not a difference between the 2 groups in our study population. Almost everybody misclassifies their own weight. So that we would call a non-differential misclassification. There are a few more ways that we can get information bias in an epidemiologic study. Another example of how this bias creeps in is if our interviewer knows the status of the subjects before the interview process. So if they know who's a case and who's a control, they might probe differently about exposures in the past. If you know someone's a case, you might say, "Are you sure you didn't smoke a little bit more? Are you sure, that's the diet that you're describing? Are you sure you didn't have any of these other exposures?" Another way is that subjects themselves may recall past exposure better or in more detail if they have a disease. This is something we call recall bias. So sometimes as a patient, if you have a disease, you want an explanation for that disease. So if you participate in a study, you might think carefully and try to recall in great detail all of your past exposures. Sometimes you may even over-remember a little bit because you're seeking an explanation. Whereas a control in a study, somebody without disease, they're not nearly as motivated. So they may participate in the study, but they might not try quite as hard to recall past exposures. So now that we've talked about bias, we need to talk about something called confounding. Confounding is a situation where we have a distortion of an association between an exposure and an outcome due to the impact of some third variable or group of variables. So confounding is a problem because it can lead to an overestimation or an underestimation of the true association between the exposure and the outcome. It can even change the direction of the observed effect. So if we have confounding, it may be resulting in an odds ratio that's less than 1, when in reality it should be in the opposite direction above 1. Confounding is most likely to occur in observational studies. Remember that observational studies are the cross-sectional, case control, and cohort studies. So let's take the example of coffee drinking and pancreatic cancer. If we were looking at the relationship between drinking coffee and the incidence of pancreatic cancer, let's say we observe an association or relative risk is above 1. It may be that coffee drinking truly does cause an increase in pancreatic cancer. Or it may be that coffee drinking is associated with something else that is confounding the relationship between coffee drinking and pancreatic cancer. We know that coffee drinking is correlated with smoking, and smoking is a risk factor for pancreatic cancer. So in this case, smoking is confounding the relationship between drinking coffee and the incidence of pancreatic cancer. So the figure on the left shows a causal relationship between drinking coffee and an increased risk of pancreatic cancer. The figure on the right shows a relationship between drinking coffee and pancreatic cancer that's confounded by smoking. So this smoking is the factor X that gets in the way of the relationship between whatever characteristic that we're trying to study and the disease that we're looking at. So in order for something to be a confounder, in this case, smoking confounds the relationship between drinking coffee and pancreatic cancer if it meets these 3 criteria. 1, smoking is a risk factor for pancreatic cancer. We know this is true from other data. 2, smoking is associated with drinking coffee. This is true as well. Many people who smoke also drink coffee. The 2 are highly correlated. Doesn't mean that if you drink coffee, you're always going to be a smoker. If you're a smoker, you're always going to drink coffee. But it just means that these 2 behaviors tend to be highly correlated. And then third, smoking is not a result of drinking coffee. So in this pathway, it doesn't mean that drinking coffee causes you to smoke, which causes you to get pancreatic cancer. It means that coffee and smoking are correlated, and smoking is associated with cancer. So how do we address confounding in an epidemiologic study? We can address it either in the design of the study or the data analysis. So in a perfect setting, we would randomize a clinical trial, and then that way all of our confounding variables would be equally allocated between the treatment groups. This isn't always possible, and so sometimes we might restrict our sample. Let's say we know that smoking is a potential confounder that we're worried about. We would restrict our sample or study population to non-smokers. It would be a criteria for joining the study. We could also match our cases and controls on confounding factors. So every time we recruited, let's say, a case that smoked, we would recruit a control that smoked so that we would have that variable equally allocated in both groups. If we've gone through the whole design of our study and we've recruited our sample, and let's just say we didn't notice a confounder, or maybe we just forgot to pay attention to it in the design of our study, we could try to look at it on the data analysis side by stratifying. So maybe we would look at the odds ratio of coffee drinking pancreatic cancer separately for the smokers and the non-smokers in our group. That's what stratification means. We could also do something called adjustment. It's a statistical procedure where we use a statistical model and adjust for a confounding variable to try to remove the effect of that variable in our data analysis. So there are a lot of things that we can do to try to handle confounding. We've gone through this whole lecture, and you may be asking yourselves now, why is the distinction between confounding and bias important? Does it really matter if the association is causal or if it's confounded? You still get the same answer of an exposure associated with disease, but it is actually critically important. So let's say cholesterol is causally associated with heart disease. Then a public health intervention designed to treat high cholesterol might help reduce heart disease in the general population. But if cholesterol is only associated with heart disease because cholesterol and heart disease are related to a specific genetic profile, the gene is confounding the relationship between cholesterol and heart disease, then all of this effort and money that we put into designing these public health programs around cholesterol won't work. They won't have any impact. And so it's really important that we understand whether a relationship is a true association or whether it's confounded. So just to sum up, biases need to be addressed and eliminated. On the other hand, confounding an interaction. All right, so just to sum up, biases reflect inadequacies in the design or conduct of a study. Biases need to be addressed and they need to be eliminated. On the other hand, confounding reflects a real association between different factors in a certain outcome. So the issue of confounding will come up in almost any situation in which we are interested in determining causality. And so it helps us understand a biological mechanism, and then it helps us determine whether or not we should invest in public health interventions. And so distinguishing between causality and confounding are critical issues in epidemiology. So hopefully in this lecture you've gotten kind of a broad bird's eye view of the difference between causality and bias and how that reflects our understanding of causal associations. The issues of bias are very complex. There are many different kinds of bias, but the two main types that we talked about today, selection bias and information bias, sort of form the bulk of the problems that we see in most epidemiologic studies. And so as you're reading the literature, kind of be on the lookout for potential biases and confounding factors in the study as you're reading them.